bad news is that I misremembered the slide order for the lectures. The good news is we're not doing neuro this afternoon. We're going to do glaucoma. This is a shorter lecture, and do you guys have anything after this? Noted. Neuro is also a fairly short lecture too. That's going to be, is it Monday, Tuesday, Wednesday next week? Yeah. Okay, so Monday we'll do neuro. Tuesday we'll do the trauma lecture. And then Wednesday we'll do the review. So the trauma lecture is a little longer, it's like 100 and some slides. But it's a good one. I like it. All right. So we'll talk about glaucoma this afternoon. Again, there's only 67 slides, so there's no chance you'll be here until 3, which is good for y'all. I will be thorough. I'm not going to fly through this thing. It's not that long. Okay, just glaucoma. Why do we have a whole 2-hour block for glaucoma? Well, because there's multiple types of glaucoma. And I think it's important that y'all understand glaucoma because you're going to have patients coming in asking you questions about glaucoma. You're really not going to be treating or managing glaucoma. There will be instances where you guys just refill medications though because the patients don't have any meds and they can't get in to see optometry or ophthalmology who's ever managing their glaucoma. So I'm fine with you guys refilling glaucoma medications for like a certain period of time. I want you to continually refill them because we have to monitor their glaucoma progress, but you guys can refill certain glaucoma meds. Yes?
So your microphone is not activated.
Is it active? Let's see if I turned it on. Sure didn't. Thank you.
How's that?
Much better. Thank you. Forgot to press the old on button. Silly goose. Okay. Alrighty. So let's talk again about anatomy of the eye. I'm going to try to break glaucoma down into really simple thoughts for you guys to understand. So I have a metaphor for the front of the eye, the anterior chamber, and I like to have people think of it like a sink. Okay? This sink always has a faucet that's running, wasting water, but it also has a drain that's always draining. And so if your drain is draining properly and your faucet's not a fire hose, there's not going to be any spillage throughout your home, right? Your sink is going to be continually draining even though the faucet's on. That's kind of what happens in the front of the eye, in the anterior chamber. There's always fluid that's being pumped into the anterior chamber, aqueous humor, okay? So that faucet is always on. But the drain in a normal eye is always draining that fluid out at a continuous rate. That pressure, though, inside of the anterior chamber is what gives us our intraocular pressure, the IOP. We measure that IOP a few ways. I'm sure you guys know what the puff test is. Anybody not had the puff test? Oh yeah, you've never had an eye exam. Go get an eye exam. Then you'll have a puff test. They blow a puff of air in your eye. It's not super enjoyable. And the machine reads the bounce back pressure from that puff of air. Another way we can do it is the Goldman tonometer, which is attached to the slit lamp. We'll numb the eye, put a little fluorescein dye into the eye, and then did you guys adjust the light on the slit lamp to the blue? So we'll turn the blue light on. It makes the tonometer tip glow, and then we actually touch the corneal surface with that Goldman tonometer, and then adjust the pressure on that gauge. That's the gold standard for reading intraocular pressures with the Goldman tonometer. Just a couple other things you can use. The tunnel pen I already talked about, and then we have an eye care machine that basically has a little, almost like a needle with a glass head on it. you shove the pointy end into the machine so you're not stabbing somebody in the eye. So just that little glass bead will actually bounce off your cornea. That one's pretty nice because you don't need any anesthetic. The Tom pen requires anesthetic, and it's pretty quick. The eye care is as well. But multiple ways to measure the IOP. So again, aqueous humor is produced in the ciliary processes, part of the ciliary body. That is the faucet that's always on. And then the aqueous will flow through the pupil into the anterior chamber, and then it will drain out of the angle in the anterior chamber. And that angle is filled with the trabecular meshwork. So the trabecular meshwork you could think of as the drain, the ciliary processes you could think of as the faucet. And it's all one nice continuous system. So here's that in a diagram. You can see the ciliary processes are these finger-like areas on the ciliary body. Will produce aqueous. That aqueous flows around the lens, through the pupil, in front of the iris, and into the anterior chamber. Floats around in there. That aqueous has a bunch of nutritional aspects to it. It provides energy to the cornea, and once it's done, once it disperses its niceness to the cornea, it will drain out through the anterior chamber angle, which is right here, trabecular meshwork, into Schlemm's canal, and into the episcleral vessels. Okay. All right. So here's another diagram, same kind of process, just a different picture. Okay, so in a normal eye, again, there's no overflow into the sink, okay? There's no spillage onto the floor, right? Now let's say you have upgraded your faucet in your house, and now that thing shoots out a lot of water, okay? If that shoots out more water than what your sink is able to drain, you're gonna have an overflow of water, and the water's gonna spill out over your sink. Conversely, if you have the same faucet, but you get a bunch of gunk down in your drain, then your drain's not gonna drain the water properly. You're also gonna have water spilling over. Spillage is not a good thing. Inside of the eye, it's all one connected area. So instead of it spilling onto the floor, it just increases the pressure inside of the eye. And that increase in pressure inside of the eye is going to cause damage to the optic nerve head. And that is glaucoma. Okay? Damage to the optic nerve head due to an increase in the pressure gradient inside of the eye. Typically, again, normal pressure for the eye is between 10 and 21 millimeters of mercury. So anything above 21 is potentially going to cause damage to that optic nerve head. And once it causes the damage, it's irreversible. So once that nerve starts to die off because there's too much pressure in the eye, it's dead and gone. Okay. All right, so the definition for glaucoma is underlined here. See, it's a group of diseases with progressive optic nerve damage and visual field loss. Okay? And again, most of the cases, the IOP is above 21. We've got two broader categories for glaucoma. You've got open angle glaucoma and angle closure glaucoma. Now, when we're talking about the angle, again, that's the area where the aqueous drains out. This is the angle right here. See, there's an angle there. This angle is open. Okay? I'll show you a couple pictures later on where the angle's closed. If the angle's closed, then the drain is closed also, so nothing can drain out. That is not a good thing. Okay? That's going to cause a significant increase in IOP, and it's going to be pretty sudden. Open angle glaucoma will typically happen when crud or pigment gets caught in the trabecular meshwork, which essentially you can think of like a dirty drain. Okay, so your trabecular meshwork has pigment in it. It's not able to drain the aqueous out of the anterior chamber, and that's going to cause the increase in ILP. All right. So you guys have all done your angle assessments when you're doing your clinical skills. The best way to assess an angle is under the slit lamp, because number one, you're under magnification, so you can actually see what's going on in the eye a little bit better. But number two, when you shine the pen light across the patient's eye, you have to be kind of like right at the proper positioning, or you're going to get false readings a lot of times. And then number two, when you're doing this, you kind of have to know what you're looking at. And if you don't, then you can misassess an angle. Okay. I have had some of the previous classes say, hey, we were doing the angle assessment, it looked like they had a shallow angle, and indeed they did have a shallow angle. So I think you guys are pretty good at it, but it's not the most accurate way to assess an angle. So this is what it should look like in the upper picture there. So you're shining the light across the eye, across the anterior chamber. It should basically illuminate the whole thing. If that angle's closed, then it's going to cause a shadow on the iris there, and you won't be able to see fully across the anterior chamber there. So you can see the bottom picture, that angle's definitely closed off. Top is open. All right, now we're going to talk about CDs, cup to disc ratio. Another analogy I like to use is a donut. Okay, so picture a round Krispy Kreme donut with the hole in the middle of the donut. Okay, Krispy Kreme donuts have a CD ratio of probably 0.4. That's pretty typical for Krispy Kreme. Okay, some cake donuts will be like a 0.15, 0.2. And cake donuts typically have a smaller hole. Krispy Kreme is about a 0.4. Okay. If, for whatever reason, the people working at Krispy Kreme drop less dough into the mold for the donut, you're going to have a larger CD ratio on that donut there, right? It's going to be like a 0.7, 0.8 because there's less dough on there, so the hole is going to be bigger. And then conversely, if they drop too much, you think like a cake donut, it's going to be a much smaller hole in the middle. So the CD ratio, you think of like a donut. We're measuring the size of the hole to the donut itself. Okay, 0.3 to 0.5 is pretty normal for CD ratios. The larger the CD ratio, it's a risk factor for glaucoma. It doesn't necessarily mean you have glaucoma, just a risk factor. And the reason it's not necessarily definitively glaucoma is because if you take a normal Krispy Kreme donut, like a 0.4 CD ratio, you take the same amount of dough into a larger donut, okay, the CD ratio in that donut is naturally going to be larger, right? You have the same amount of dough, it's just got a larger area. The donut area is larger, so it's going to have a larger hole in the middle of it. Okay? We call that a physiologically large optic nerve head. So glaucoma is one of those diseases that it's kind of a silent disease, right? You're not going to notice any vision changes with glaucoma because it's such a slowly progressing disease unless you have angle closure glaucoma. Like typical open angle glaucoma is real slow progressing. You lose peripheral vision first with glaucoma, so your central vision is not affected at all. So patients don't come to the eye doctor or worry about their vision because they still have 20/20 vision. Okay. So glaucoma is oftentimes underdiagnosed for that reason because patients don't come in to the clinic. But then sometimes it can actually be overdiagnosed when you're in clinic as well. I think that the overdiagnosing of glaucoma has really subsided based on technology that we have now with the OCT scan. So we can measure the size of the optic nerve head and down to the micron to see how much optic nerve fiber layer is still there. But before we had an OCT, we were really just assessing a patient's glaucoma status based on the CD ratio and the visual field. So patients were having larger optic nerve heads, and by having the larger optic nerve heads, they had a larger CD ratio. So they may have had like a 0.7 CD ratio, but they just had a large nerve, and docs were diagnosing them as having glaucoma, even though they didn't have glaucoma, they just had a large CD ratio. It's kind of overdiagnosed and underdiagnosed. But it's less overdiagnosed now because of technology. It's great. All right. Another picture of the cup to disc ratio. We're measuring the size of the cup to the disc itself. This is about any guesses? It's not 1 to 2. This I call it a 0.3, probably. Okay, we got examples here. 0.1 on the left side, 0.5 or your 1 to 2 on the right side. Okay. 0.8 and then 0.9 in that picture on the right. Now that 0.8, I can tell that I don't have to do any other testing. I know this patient with a 0.8 has glaucoma because they have this notch right here. Okay? That notch is indicative of glaucoma. Okay? The nerve is dying in that area, and that patient has glaucoma. Anytime the nerve is not round and it's got a notch in it, that's glaucoma. This is also glaucoma. Okay, that's a large CD, it's probably like 8.5. And the other thing we look at with glaucomatous discs is the vessels. See how this vessel comes in and then sort of disappears? Okay, can't see the vessel going down. You can see some of these going down in. Oh, like this one disappears, this one's gone, this one's gone. They're not actually gone, but that disc has been so excavated away that it ends up like we call it bean potting. So you can think of like a pot that you put plants in, and it'll have sometimes a smaller opening than the actual pot itself. So that's what's happening with the vessels. It's going in the hole into the cup and then coming down around the side of that pot. So it looks like it's disappearing. Another thing that we look at is asymmetry between both eyes. So this is the same patient, but the disc on the right, or in this case the left-hand picture here, is much larger. I'm sorry, the CD ratio is much larger than the CD ratio in the left eye. Okay. So this patient would be much more suspect for glaucoma, and probably does have glaucoma in that right eye. Maybe in the left too, but it's just not quite as bad. Okay, another thing that we do for testing testing glaucoma patients is a visual field. You guys can do a basic visual field test. Okay, so if you have a patient close their eye, you can put fingers up in their peripheral vision and have the patients count fingers for you. Call it the finger count. That's a very gross test for glaucoma visual field testing, but it's actually pretty accurate. You're not going to determine exactly the patient's visual field, but you'll be able to see if they're like missing a quadrant of their visual field or maybe a hemisphere. The finger count test is also useful if you're testing a stroke patient. So if a patient has a stroke in the visual cortex, then when you have them close one eye, they're going to be missing half of their visual field, so it'll just be black out there for them. You'll be able to see your fingers, but they won't be able to see them until you get almost to the midline. So that's indicative of a stroke. And that you can definitely tell something's not right with that patient. Do you guys practice the finger counting? Yeah, just do it one eye at a time. So on the printouts for our visual field machine that we have, this is what we'll use to this printout here is what we'll use to educate the patients. It's not really how we track visual field loss, but Basically, if there's a lot of ink on the printout like this, that's bad, okay? So this is all blacked out over here. The patient can't see in that area. They can just see this tiny little bit of vision. So this patient's legally blind here because of their visual field being minimal. This is normal glaucoma right here. Usually it will lose either the superior or inferior visual field. Okay? And then this is a normal eye. So we've got this blind spot right here. What is that? Yeah, that's where the disc is. That's a physiological blind spot right there. Okay, we already talked about sonometry, but that's another measurement that we'll get on glaucoma patients or glaucoma suspects. Got the puff test. We talked about Tonopen and Goldman tonometry as well. This is a picture of what the Goldman tonometer looks like when it's actually on the eye. So there's the Goldman with the blue light. We'll applanate, we'll put the fluorescein stain on the patient's cornea. We'll also numb the patient's cornea. And then this probe has little prisms in it. And the prisms will have an upper circle and a lower circle, okay? We call those Myers. And what we're trying to do, once we're on the patient's cornea, we're adjusting those Myers with the pressure gauge. This guy right here is gonna adjust the pressure. And then we're just looking to interlock those Myers like they are, okay? We don't want them overlapped or underlapped. Just want them interlocked, just like this. Once we have that position, then we'll look at the Goldman gauge, and whatever the number is for the IOP, that's what the IOP is. Okay. Here's one thing that you can do if we do Goldman tonometry. You can stamp a patient's cornea. So there was a Goldman tip on this patient's cornea at one point, and it was either pressed too hard, or what I have idiotically done in the past is clean the Goldman tip off with alcohol and then not let the alcohol dry. That is not a good thing to do for a patient's cornea. I did that when I was in my 4th year externship. I stamped a patient, and my preceptor said, "Did you let that alcohol dry?" And I said, "I probably didn't." And then I learned to always let the alcohol dry. Otherwise, you'll stamp it. Now, the patient's going to be in a little bit of discomfort after this. Obviously, I just removed epithelial tissue, but they'll be fine in like a couple hours. You feel bad, looking pretty dumb after that. Okay, we're going to talk about ocular hypertension. Ocular hypertension just means that a patient's IOP is above normal, but there's no optic nerve damage. The anterior chamber is normal, and there's no visual field loss. So you can have high intraocular pressure, but again, if there's no visual field loss or no damage to the optic nerve, you don't have glaucoma. You have ocular hypertension. Now you may develop glaucoma in the future, but you don't currently have glaucoma. And we call that ocular hypertension. These patients have to be monitored annually because there's a good likelihood that they will develop glaucoma, but it's not technically glaucoma if the IOP is just high. You have to have that optic nerve damage and the visual field loss to be true glaucoma. All right, now we're going into POAG. This is the most common type of glaucoma, primary open-angle glaucoma. Most glaucoma is POAG. Okay? And again, usually primary open-angle glaucoma is due to a drain issue. So the trabecular meshwork either has pigment in it or maybe other fibrotic tissue in it, and it's not allowing that aqueous humor in the anterior chamber to drain out. So the pressure is going to go up, and then they're going to develop optic nerve head damage, loss of nerve fiber layer. Okay. So signs and symptoms for patients with POAG are, again, hard to appreciate early, okay? This patient may notice that they've got issues. They may be bumping into a wall a little bit more often. Sometimes I do that, and I'll be like, dang, do I have glaucoma? Usually it's no, I'm just clumsy. But Sometimes that'll be something that patients state, like, can you check my eyes? I've been bumping into walls lately. And your peripheral vision is, again, the first part of your vision to go with glaucoma. And so it progresses as the pictures indicate on the bottom there. Normal visual field, kind of closed off, more closed off. You can see why we take patients' licenses away, right? Picture little Jimmy bouncing his ball. Ball rolls into the street, okay? You can kind of see it, not right away here. Less reaction time here. You don't see Jimmy, you just feel the bubble. And you run over Jimmy, okay? So we'll take licenses away from people for that very reason, okay? For their safety and for the safety of others. And that's end-stage glaucoma. That's legal blindness right there. Okay, risk factors for glaucoma, age, genes, right? If your family has glaucoma, immediate family, mom, dad, brothers, sisters, good chance that you're on the risk factor for developing glaucoma as well. Okay. With hypertension, there's actually not a relationship between that and glaucoma. They're two separate systems where the aqueous is produced and it drains out. That's separate from systemic hypertension. So hopefully none of you have a family history of glaucoma in here. Okay, if we have a patient coming in with glaucoma, we're going to measure their IOP. Okay, we'll check their pupils. And then we're going to do a full fundus exam, dilated. We'll do an OCT on those patients to check, again, down to the micron, how much nerve fiber they still have, and then a visual field test as well. We measure the thickness of the cornea as well. That's called pachymetry. And we do that because the thickness of the cornea can actually affect a patient's IOP reading. If you have a real thick cornea, you're going to have an artificially inflated IOP. Because again, the way that we measure IOP is by either from the puff test, the bounce back pressure off the cornea, or by applanating the cornea with the Goldman. So if the cornea is thicker, it's going to be stiffer. You're going to require more force to indent that cornea a little bit, and the IOP is going to be artificially higher than what you think it is, or than what you're reading. Conversely, if you have a thin cornea, your IOP might be lower. So you might have a quote-unquote normal IOP, but if you got a real thin cornea, you could still have, the IOP could still be too high for what your eye should be. Okay? You might fall in normal ranges by the reading, but not in actuality because your cornea is too thin. So we'll measure the thickness of the cornea as well. Okay, how do we treat glaucoma? Mostly, we're treating with medications. Okay, and the medications do one of two things: either decrease the amount of aqueous being produced, or increase the drainage in the eye. Okay. So I talked about that with uveitis yesterday. I said patients with uveitis, even though they have inflammation going on inside of the IOP is actually lower in the eye with the uveitis going on, because that inflammation actually opens up the trabecular meshwork and allows more aqueous to outflow through that drain. So one of the glaucoma medications that we'll give is a prostaglandin analog that actually induces inflammation in the eye, which opens up the trabecular meshwork and allows more drainage out of that. Some of the other drugs we'll give are beta blockers, and that will decrease the amount of aqueous being produced. Okay. There's another rule of thought with glaucoma treatment, and that we can just do surgical interventions right away. So ophthalmology can go in with lasers and blast away at trabecular meshwork and get rid of a lot of the pigment that's in the way there, and that will actually allow more outflow as well. There's pros and cons to surgical interventions. A big pro is you don't have to worry about a patient taking a drop every single day. Some of these patients have to take multiple drops throughout the day. That's really hard for a lot of patients to remember to do. If it's just one drop before bedtime, they can just keep it on their nightstand and pop a drop in right before they go to bed. But when they're taking multiple medications throughout the day, that's much more cumbersome on the patients. So obviously patient compliance is going to be much better if you have a surgical intervention. Cons to surgery is sometimes that surgery can induce an inflammatory response in the eye, creating like an iritis or uveitis, which is not good for the eye, but it actually also increases the outflow of aqueous, so it's good for the glaucoma treatment. So these are some of the medications that we prescribe. Timolol is the most common beta blocker. We've got some alpha-2 agonists, brimonidine, okay, and latanoprost, bimatoprost are the prostaglandin analogs that are most common. Side note about bimatoprost, one of the side effects for prostaglandin analogs that patients were noting is that they were getting longer, thicker eyelashes when they were taking the prostaglandin analog. And Big Pharma was like, I can make money off of that. So they reformulated bimatoprost into what's called Latisse. And Latisse is a prescription that you can get from an eye care provider that is meant to increase your lashes. And it works quite well. I prescribed it to my wife. She enjoyed it. There are systemic side effects potentially to glaucoma drugs. So you're just going to want to, before you're prescribing a patient a medication, you're going to want to do a meds check to make sure that they're not taking anything that could potentially interact with increasing the IOP if they have glaucoma. We also take a look at that as well. If they're on heart medications like beta blockers for some heart condition, we either will not put them on a beta blocker or we'll make sure that the beta blocker is not going to interact with the systemic beta blocker that they're already taking. Okay. So you do have to pay attention to systemic side effects with glaucoma medications. Okay, again, we can do surgical treatment. Ophthalmology will blast that laser in through the trabecular meshwork. That will increase the outflow. It's usually the way that they go now for surgeries because it's all outpatient. It's just under the slit lamp. They attach a laser essentially to the slit lamp and then pew, pew, zap through the trabecular meshwork. Okay, so this picture is of nerve fiber layer loss. Okay, let's see if we can see where loss is. This area of retina looks just a little bit different than this area of retina here. Right, this one's kind of a little more striated. This one's much less striated. There's also a notch right here on the nerve. Okay, that notch is indicative of glaucoma and nerve fiber layer loss. So that's what happens in the retina. The photoreceptors and the nerve fiber layer are all dead right here, and those photoreceptors and the nerve fiber layer that comes into the optic nerve head kind of excavates itself away, and that's what creates that notch. Look at that arrow right on.
Is it also superior to the macula, like that area is also
Like up here?
like a little bit higher, yeah, like that area?
So not so much up here. Usually glaucoma will respects kind of the midline, the horizontal midline. So it will affect superior or inferior. If you have end-stage glaucoma, it will affect both, but it will affect one more than the other. And then there's a lot of nerve fiber layer up here still, from here to here. That's all healthy nerve fiber layer. So there's not glaucomatous damage per se up there yet. This is a printout of our OCT, optical coherence tomography. This kind of, you can think of like an ultrasound for the eye. So this will measure down to the micron how much nerve fiber there is. So you can see in the right eye, the average thickness here is 104. That's a great number. 91 is actually a great number too. But we can't always pay attention to it's green, so it's good to go. We actually have to look further in here. So you can see there's asymmetry. We said that's a risk factor for glaucoma. There's a pretty good amount of disc asymmetry there. And then the cup to disc ratio is quite a bit larger here in the left eye than it is in the right. And then we'll look at the printout here, and you can just see there's the dark gray. There's just a lot less dark gray in that left eye than there is in the right eye here. And then this picture right here is indicating that visual field loss, the nerve fiber layer loss in that inferior arcade there, which corresponds to the visual field printout, and the patient has superior visual field loss. So inferior retinal nerve fiber layer loss, superior visual field loss there. Another thing we look at is hemorrhages on the disc. If there's bleeding on the disc, this is a dot, blot, or flame heme right here. It's flame heme, yeah, very good. However, flame hemes around the disc, we don't call flame hemes, we call them Grant's hemes. But it is a flame heme, you're right. Good. Very good. So if you have a Grant's heme or a flame heme on the disc, that's indicative of glaucoma as well. One of the treatments they can do for advanced glaucoma is actually put what's called a bleb into the eye. So they will essentially bypass the trabecular meshwork. Ophthalmology, this is not something I do. Ophthalmology, the glaucoma doc for ophthalmology, will go in and make an incision in the actual trabecular meshwork and take out an area, and then that will fill up this part of the episclera right here, and that aqueous will then get drained through the episcleral vessels. They call that a bleb, filtering bleb. If the patient has a bleb, it should look like this because aqueous is outflowing through the eye. If they have a bleb and it's flat, then it's not working. So, note to self. If you see a patient with that, if you're like assessing eyes for conjunctivitis or something, and you're looking at their eyes and you pull that upper lid up and you're like, oh God, what is that? Probably normal, probably a glaucoma bleb right there. They do look pretty weird though when you first see them. That is not normal. It actually is. Okay, so that's POAG. Any questions on POAG? Okay, typically, again, not typically. The angle's definitely open in POAG. Typically, the drain is clogged. IOP is typically going to be higher than normal. Okay? And then medications or surgical interventions are the way that we treat it. All right, so normal tension or low tension glaucoma is similar to primary open-angle glaucoma, but you can see the tension or the IOP is normal or low. So the way that we treat and manage glaucoma, you can't cure yourself from glaucoma. We're only managing the pressure. We're lowering the pressure in the eye so that there's no more disc excavation going on. So the nerve fiber layer doesn't die. Okay? You still have glaucoma, but we're managing it. We're keeping the pressure where we want it via medications or via surgical interventions. If the pressure is already low or normal, it's much more difficult to treat these patients because it's hard to lower something that's already low, right? If an IOP is 30, that's obviously above normal. It's much easier to lower that to 20 via medications and get rid of the continued nerve fiber layer damage. Then if you have a patient with an IOP of 15, it's much harder to get a 15 down to a 10 because there's a lot less pressure that you can deal with there. So it's a lot harder to treat. So what do I do with normal tension or low tension patients? Punt. Ophthalmology. There's a glaucoma specialist that's done their 4-year residency in ophthalmology and then a 3-year fellowship in specifically treating glaucoma surgeries. That's not my wheelhouse. That's theirs. Punt, 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 punt. They're going to do a lot more of the aggressive treatments. That bleb is something that their patients get, and a lot more surgical interventions as well. Very difficult to treat. Okay. Here's the risk factors. Really similar to primary open-angle glaucoma, except for sleep apnea. Okay, so if you have sleep apnea, you may be at a higher risk for normal tension glaucoma, because the ocular perfusion pressure will increase significantly when you stop breathing at night. Okay? So if you have sleep apnea, wear your CPAP so you don't get normal tension glaucoma. But enjoy your 50% VA disability rating. Did they just drop it? Or they're going to? What is it now?
It's like 30 or 20.
Lame. I was going to get real chunky before I retired and develop CPAP. So I won't do that now. I make a happier wife. All right. Now we're going to move on to acute angle closure glaucoma. Okay. This is an ocular emergency. Okay. Not too many of them. We'll talk about ocular emergencies in the trauma lecture. I have a little triage section for you. But we have to treat acute angle glaucoma right away. This is different from open angle glaucoma, and obviously that the angle is closed. So if the angle is closed, there's nothing draining. That pressure is going to skyrocket very quickly because the faucets are still on, but the drain is non-existent right now. So pressure increases greatly in acute angle closure glaucoma. And we said you can be in the 30s, upper 20s or 30s for POAG. Patients with acute angle glaucoma are in like the 50s, 60s, 70s for their IOP. So that eyeball is going to be rock hard, and they're going to be in a lot of pain. Typically, POAG, open angle glaucoma, is not going to be any sort of pain related to it. Angle closure glaucoma definitely has pain. Patients are going to have a massive headache. They're going to be nauseous. They may be vomiting. Okay? They're going to be in a ton of pain because that angle is closed. So the blurry vision, they may have halos around the lights because that cornea is going to swell, becomes kind of frosty. Intense pain, headache, and nausea and vomiting. Okay, signs of angle closure glaucoma are going to be a fixed mid-dilated pupil. So the pupil is not going to respond at all. So when you're doing your pupil tests, that pupil, if you're having a patient with angle closure, when you shine the light into that eye, that pupil's not going to move at all. It's going to be fixed and mid-dilated. Okay? Obviously, they'll have a shallow anterior chamber. It's going to be closed because the angle's closed off. Some ejection of the conch, some swelling of the cornea. Again, when the cornea is swollen, that's going to get kind of that hazy view through it. And then 60 to 80 millimeters of mercury on the IOP readings. Okay, unfortunately for the ladies out there, you are at a higher predilection for angle closure glaucoma. Not to say that men can't get it, it just happens more often in females. Also in hyperopes. So any far-sighted people in here, you are at a higher risk for angle closure glaucoma as well. Because, remember I said in high myopes, the eye is elongated. When the eye elongates in a high myope, that really opens the angle up. But if you have the converse and you're a high hyperope or farsighted, the eye is shrunken quite a bit and it contracts everything, and that leads usually to a shallower angle, and you're more prone to having the angle close. So bad to be really nearsighted, also bad to be really farsighted too. Hopefully you have normal eyes. Sometimes patients who have shallow angles and enter a darker room will onset acute angle closure. Okay? And the reason for that is when you enter a room that is darker, your pupil is naturally going to dilate more. And when that pupil dilates, the iris spreads out towards the periphery, and that can actually close the angle off as well. All right, this is an example of a narrow angle there. So this is under the slit lamp here. So what we're looking at is the cornea through this beam here, and the iris is right here. There should be, well, you can see there's kind of a shadow in between here, between this line and this line. There's kind of a shadow in there. It should be a lot larger than that. If that shadow is very small or non-existent, then the angle is closed. It should be like 3 times the size of the cornea in there. So you should see a large shadow in an open angle. This one is closed off. And then the picture on the right, you can see that the pupil is kind of blocked off on here. So like this angle is completely, there's no shadow at all up here. This pupil has been blocked. The angle is completely closed up here. All right, with acute angle closure glaucoma, again, it's an ocular emergency. You've got to start treatment right away on these patients. You should have either very quick access to optometry or ophthalmology, or if you don't, you should have an angle closure kit in your clinic somewhere. That's going to have very specific medications that you're going to give to a patient with acute angle closure glaucoma. Okay, you're going to give them timolol. Timolol lowers the IOP right away. Again, that's the one that decreases the aqueous production. Okay. You're going to give them pilocarpine right here, the miotic agent. Okay. You're going to give them pilocarpine. That is going to constrict the pupil. If you constrict that pupil down, it's going to take all that iris tissue that's closing the angle off and pull it in towards the middle and open that angle up a little bit. So pilocarpine is something you're going to give on angle closure, and then timolol as well. Sometimes you give acetazolamide. Okay, that's going to just that diuretic that's going to make them pee a lot of stuff out and help to lower some of the fluid inside of the body. But you got to get the angle open. Once the angle's open, then IOP is going to get down back to normal. And the patients are going to know right away when that angle opens up because their headache's going to go away. You'll see the haze go away on their cornea, and the IOP readings that you're taking will go down significantly when that angle is finally open. Once that's opened, they're going to get punted over to ophthalmology, and ophthalmology is going to do a preventative surgery called a laser peripheral iridotomy. Okay, laser iridotomy. Otomy means to poke a hole through. Ira is the iris. So they're blasting a laser hole through the iris in the periphery, and that's going to act as essentially an emergency drain. So in case the angle does close off again, the aqueous will at least be able to exit through that peripheral iridotomy. We had a few people with ICLs in here. If you have ICLs, you have LPIs. You have peripheral iridotomies. Because when they put that ICL in, it pushes your iris forward a little bit, making your anterior chamber a little more shallow, and you're at a higher risk for angle closure glaucoma. That's why they preventatively put these laser holes through your iris. I don't know if you knew that, but now you do. Okay. This is what they do for the peripheral iridotomy. Okay, so they'll open that angle back up, and then they zap, zap, zap on the peripheral iris. Okay, this is a picture of what the angle looks like when it's completely closed off. Okay, this void in between here is the pupil. This is the iris. This is the cornea. Okay. This iris should be flat down here on the lens. It's not. It's pressed up here. It's completely closed off. Okay. That is going to dramatically increase the IOP inside of the eye. Patient at the top here, which eye is affected? Which eye has angle closure? Yep, patient's right eye, very good. So that eye on the left in the picture, how can we tell that? Injection, yeah. Somebody said haze. Yeah, the cornea is pretty hazy. If you look behind the cornea, see that pupil? See how much larger that pupil is than this little beady eye here? Okay? That's a fixed mid-dilated pupil right there. Her IOP is going to be, I'm assuming this is a lady, it could be a male. It's definitely an older person. That IOP is going to be very high right there, 60s, 70s. So you got to put the drops in the eye to open that angle back up. We're putting a miotic drop in there to force that iris sphincter to work and open that angle back up. And then obviously timolol to decrease the production of the aqueous. Okay, this is an iridectomy. So otomy means to puncture a hole through, ectomy means to remove tissue, same in the iris. So they've removed a bit of this patient's iris. They won't do that all that often. Usually they'll just use the laser to puncture a hole through, but an iridectomy is also available there. Okay. All right, a couple more slides to go. Let's take 10, unless you want to power through. I don't care.
Power through.
Power through? All right, if you need to take a break, just take one and then come on back in. I'll just continue to power through. All right, so looking at the pupil here, that pupil doesn't look super round, does it? It's actually a little peaked right there because that iris tissue is missing, so there's not as much muscle tension there for the sphincter to work. So that's why that pupil's peaked right there. Anytime you have a peaked pupil, something has been messed with on the eye. There's either something wrong or they've had some surgical procedure that's causing the peaked pupil. Normal pupils should be completely round. Okay, once you have acute angle closure, you're always at risk for another angle closure attack. And so you only get acute one time. If you have more angle closure attacks, it's going to be chronic. Normally, chronic angle closure, the patients have already had the iridotomy done, so it's not as big of a deal. You can still get an increase in IOP. It's just not in the 60s, 70s, 80s. Okay? But we're still monitoring these patients all the time, and they'll probably be on glaucoma medications like timolol to decrease the aqueous production to prevent a lot of these chronic angle closure attacks from happening anyway. Sometimes it's asymptomatic, and again, we say that because normal glaucoma, POAG, is not going to be symptomatic for the patients. Only when you get that extremely high intraocular pressure will you actually have symptoms of pain, headaches, and blurry vision. So with chronic angle, the angle's still closed, but it's more like open angle closure glaucoma than it is an acute angle closure glaucoma. So once a patient has had glaucoma or a diagnosis, or sometimes even in the initial glaucoma workup, we'll do what's called gonioscopy, where we're actually assessing the patient's anterior chamber angle. We can't assess the angle if we're looking through the slit lamp head on, because optics won't allow us to actually look to the side of it. So you have to take this gonioscope. You have either a 1 mirror or a 4 mirror, and these mirrors will allow you to look in and then bend the light so you can actually see the angle in a patient's eye and see if it's how much pigment is there, if it's open, if it's closed. So this is what the views are going to look like through a gonioscope. So obviously we have the patient's iris right here, and then we have the sclera right here. Okay, and this pigmented area is the angle itself. So the trabecular meshwork lies within that angle there. And you can see this one's more pigmented than what the iris color is. So potentially that patient's going to be more prone to like a POAG attack because there's a lot of pigment in the drain there. The picture on the right shows synechia which are adhesions of the iris, again, to something. You can have anterior synechiae where the iris adheres to the cornea, posterior synechiae where the iris adheres to the lens, and then peripheral synechiae where the iris is adhering to the angle. It's problematic when the iris adheres to the angle because then the angle is closed in that particular area, and that can cause an increase in IOP. Okay, so for chronic ankylosing glaucoma, again, you may have, well, I punt these again to ophthalmology, chronic ankylosing glaucoma. They're going to do more of the surgical interventions. They may put a bleb or a shunt in there. It's a lot more aggressive treatment with the glaucoma docs in ophthalmology than just simple medications. It's going to need some sort of surgical intervention. Okay. Next, we'll talk about congenital glaucoma. This is unfortunate for infants. Some infants can get glaucoma. Again, most people will develop glaucoma if they get it in the later stages of their life, 50s, 60s, 70s. If you're born, unfortunately, with glaucoma, that's not a good thing. And a lot of it has to do with other congenital malformations or deformities. So if they have other systemic diseases that they're born with, they're at a higher predilection for congenital glaucoma too. The eye is just not made normal. So again, we talked about dacryostenosis, where the nasolacrimal duct is obstructed, and that can cause excessive tearing for obvious reasons. Congenital glaucoma will also have excess tearing in an infant. So if you have a baby coming in, mom's saying or dad's saying that the baby's constantly tearing, hey, this should be one of the differential diagnoses that you're trying to rule out. So either if you have the ability to take an intraocular pressure or look inside the eye, great. If not, make sure you're referring that patient over to optometry ophthalmology. Okay, these are some other signs that you may see. Excessive tearing, again, is going to be one of the main differentials. They're the main signs that you see. And again, nasolacrimal duct obstruction of the dacryostenosis is going to be one of the differentials that we have. Hypostria, these are just lines in the cornea. They're horizontal lines in the cornea. Okay. Not super important. This is not hypostria. These are vertical lines in the cornea. These would be like a voigtstria. Okay. Don't have to worry about that. So this patient has, it's called ophthalmos. So the eyes are, the corneas are larger, called megalocornea here. This is not necessarily congenital glaucoma, but the patient is still going to have potentially higher intraocular pressure. This cornea is hazy, okay? Something's wrong there. The IOP is increased in this patient, and that's indicative of congenital glaucoma and the tearing. Okay, so how do we treat an infant with glaucoma? Medications a lot of times, and then we're just waiting for them to grow, because as they grow, that eyeball will elongate, and hopefully that angle ends up opening up. In some cases, if you can't get the IOP to lower, they'll need surgical interventions. And again, I'm pumping this all day to ophthalmology, because they're the pros. Okay, you can get secondary glaucoma. This is not true glaucoma. Okay, you're getting an excavation of the optic nerve head because something else is happening. So there's several different ways to get this. Trauma is one. So if you get hit in the eye and the angle closes off because of that trauma, the IOP is going to skyrocket in the eye and you'll get damage to the optic nerve head. Okay, that's traumatic glaucoma. They'll get surgery and hopefully fix the angle that's been recessed, and then continue to monitor, but they don't necessarily have glaucoma. Okay? Once they get it fixed, the damage is usually null. Okay, we've got neovascularization again here. Remember I said you can get neovascularization of the disc or elsewhere, or you can get it on the iris. If you have neovascularization on the iris, okay, that blood, those new blood vessels on the iris can grow into the angle, and that will block the angle off. Okay, and that will obviously increase IOP and cause glaucoma. So we're giving anti-VEGF shots to patients with neovascular glaucoma and also IOP medications. Once we get the neovascularization under control, then we're not going to have to worry about the IOP anymore. It will go back to normal. Okay? And again, we talked about diabetic retinopathy, vein occlusions, artery occlusions, and other ischemias. Okay, with these, because IOP is not getting into the 60s, 70s, or 80s, they may be asymptomatic. They may not have any pain. They may have pain, depends on what the IOP is going to be. Okay, but they're also going to have other underlying conditions. Right, so when a patient comes in for their annual diabetic eye exam, I'm looking very hard at the iris to make sure there's no neovascularization on the iris at all, potentially closing off the angle. You can see the neovascularization in this picture. Okay, this is neovascularization that shouldn't be there on the iris. Okay, there's more neovascularization here. This neo is closer to the angle, so that's more suspect for something that would raise the intraocular pressure. Okay, another picture of neo, not null. And then you can get steroid response glaucoma as well. So talk about systemic steroids being potentially a risk factor for early cataracts. Steroids can also increase intraocular pressure, whether it's systemic steroids or topical steroids. That's why after refractive surgery, when you get the steroid drops, you have to come back for your follow-ups, and we're going to do the puff test on you. We have to make sure your eyes aren't responding to the steroid and increasing the intraocular pressure. If they are, then we have to change your steroid out or give you something else for the healing process there. Okay, lots of other types of glaucoma, but the main two are going to be primary open angle closure glaucoma and acute angle closure glaucoma. Remember, POAG is going to be pretty asymptomatic. Hopefully we can manage it early enough that there's not a significant amount of optic nerve head damage, medications, or surgery. Acute angle closure glaucoma, very painful, very high IOP, hazy cornea. It's an ocular emergency. You've got to get the IOP lowered as soon as possible. Okay. Remember, glaucoma, by definition, is progressive optic nerve head damage with visual field loss. Okay, if you don't have optic nerve head damage and visual field loss, you just have a high IOP, then it's just ocular hypertension. All right. Any questions? Adios.